So we're going to take a look at blood pressure regulation as it relates to cardiovascular. Very similarly to how we've talked about in previous weeks, red blood cell production in the presence of hypoxemia and polycythemia, etc., etc. We're going to take a look, for example, at what happens in blood pressure regulation in normal circumstances. So for a stimulus of declining blood pressure, you'd see arterial blood pressure falls below normal range. Let's say that there's a GI bleed or there's trauma. So what's going to happen normally is we'll get impulses from baroreceptors that are found in the carotid sinus and in the aortic arch, and those are going to be inhibited. Those aren't going to be stretched as much as they would with normal blood pressure. If there's normal blood pressure going through the vessels, the aortic walls are sufficiently stretched. In declining blood pressure, as you can imagine, the blood vessels are going to be closer into contact because there's going to be less blood pumping through them. So they're going to be inhibited. What that's going to do is going to stimulate the vasomotor centers of the brain. That's going to stimulate a fight or flight reaction. So sympathetic efferent is going to have increased heart rate and increased heart force. That should hopefully increase cardiac output if you're increasing stroke volume and you're increasing heart rate. It's also going to stimulate vasoconstriction via the smooth muscle in our blood vessels. So that should increase your peripheral resistance. So if you have an increased cardiac output and increased peripheral resistance, that should bring your blood pressure back up to normal range. If there's rising blood pressure, well, we're going to go through basically the opposite steps. So the baroreceptors in the carotid sinuses and the aortic arch are going to be stimulated because the blood flow through here is going to be relatively high. The aortic walls and the arterial walls are going to be stretched apart a little bit more. That's going to inhibit the vasomotor center. That should stimulate the heart rate to decline. That should stimulate the blood vessels to relax a little bit and allow for vasodilation, which should increase blood vessel diameter. If you have the same amount of fluid going through pipes, which are now twice as large, that pressure should come down. So if you have decreased resistance, decreased cardiac output, that should return your blood pressure to normal homeostatic range. So that's normal physiology. By definition, blood pressure is the force per unit area exerted on the wall of a blood vessel by its contained blood. This is expressed usually in millimeters of mercury, mmHg, and it's measured in reference to systemic arterial blood pressure in large arteries near the heart. What we typically use is the sphygmomanometer, which basically gives us a good non-invasive guess about what the actual blood pressure is, unless you're going to throw in an A-line or you're going to do some invasive techniques to go directly into the heart and measure what's actually going on. The typical blood pressure cuff blood pressure measurements that we use are basically a guess, a reference, using the brachial artery as a reference point. So the differences in blood pressure within the vascular system provide that driving force that keeps blood moving from higher to lower pressure. You're going to have higher pressures around the large vessels around the heart, so that you're going to start with blood coming out of the left ventricle going into the aorta. The left ventricle is going to be that main pump, so it's pumping at large amounts of pressure, and then that pressure is going to be lower down in the legs, down in the smaller arteries of the arms, etc. So blood's going to go from an area of larger force to an area of larger pressure to lower pressure, and that's going to result in perfusion. Okay, and perfusion is going to be bringing oxygenated blood to the tissues. So we look at a couple of equations. Blood pressure is going to be cardiac output times the total peripheral resistance. And we know cardiac output is heart rate times stroke volume. And the stroke volume is the amount of blood ejected from the left ventricle during each contraction. So those are some definitions, and we're going to take a look at how those can be manipulated and how those play a role. Blood flow is controlled by changing the diameter of the vessels. All right, and resistance to flow arises chiefly from three different areas. There's blood viscosity, which is essentially constant. You typically don't get a rapid change in blood viscosity. There's total blood vessel length, which is considered a constant as well. But the big one to look at is blood vessel diameter. And we manipulate blood vessel diameter all the time with things like nitroglycerin, sympathetic and parasympathetic reactions. So fight or flight's going to specifically vasoconstrict and specifically vasodilate other areas, but this is the one that we chiefly manipulate, is blood vessel diameter. So Pusili's law, everybody's favorite, relates the rate at which blood flow through a small blood vessel with the difference in blood pressure at two ends, which is P, the radius, A, and the length of the artery is L, and the viscosity of the blood is N. Looks complicated. It's really not that much of a big deal because most of these are constants. In English, when you take a look at the math, what you find is that the radius of the artery is the most easily modified, okay, for vasoconstriction and vasodilation. So if you double the size of the tube, if you double the diameter of the tube, think about vasodilation, resistance to flow decreases by 16 times. So total peripheral resistance decreases, so blood pressure is going to decrease. If you decrease the radius of that artery by vasoconstriction, then peripheral resistance goes up dramatically and blood pressure goes up dramatically. So then you might have heard, or you might remember from the Frank-Starling law, which states that increased venous return increases the ventricular filling and stretches the cardiac muscle prior to contraction. Right? So this is why if a person faints, you elevate their legs. It increases venous return to the heart and increases their blood pressure, theoretically. One thing you do need to understand is that the Frank-Starling law only is effective and only is a law in healthy hearts. As hearts become damaged, myocardial cells don't function properly, they stop paying attention to the law. As they start getting stretched out, things like congestive heart failure and cardiac hypertrophy, they stop really paying attention to the Frank-Starling law. So going back to anatomy a little bit, let's remember the three layers or the three tunics of blood vessels. I'll go down to the bottom and look at tunica externa, also known as tunica adventitia. So you might have learned these as sort of AMI, like a heart attack. So tunica externa is the most external part of a blood vessel. In the middle is the tunica media, sometimes this is called muscularis, and that has smooth muscle that's regulated and innervated by the sympathetic nervous system, so fight or flight, and it's important in controlling vasoconstriction and vasodilation of blood vessels. And then the inner layer, the tunica interna or the tunica intima, like intimate, is the endothelial layer that lines the lumen, lines the opening of all blood vessels. So here we see here the adventitia with some fibroblasts on the outside. In the middle throughout here is the media, where the smooth muscle cells are, and those are going to contract and relax, which again is going to affect that diameter. All right, it's going to affect that radius of the blood vessel. Then on the inner aspect we have the intimal cells, which are lined by endothelium, and we'll pay more attention to endothelium in a couple of slides. Pay attention, try and remember what this stuff is. Endothelium is going to be secreting things like nitrous oxide, which is going to have an important role to play in managing that blood vessel diameter, blood vessel radius. So if we take a look at a couple of cross sections, you start to see that in early atherosclerotic disease, you see things like fatty streaks, which are really the earliest signs, and looking specifically at blood vessels that we can see that there's issues. And this is deposition of cholesterol. We then start to see more atheromas, and then finally you start to see fatty layers and plaques developing. There are two different types of arteries chiefly that we're concerned with. There are thick-walled arteries near the heart, the aorta and its major branches. These are known as elastic or conducting arteries. They allow low resistance conduction of blood. They withstand and smooth out large blood pressure fluctuations. And if you can think about just an artery relaxing and contracting with contraction of the left ventricle, and allows blood to flow continuously throughout the body. We then have the muscular conducting arteries and arterioles. These are a little bit more distal, right? They're going to have a thick tunica media, the thick muscularis with more smooth muscle, very active in vasoconstriction. The arterioles are the smallest arteries. They're going to lead on to the capillary beds. If we look at systemic blood pressure, systemic blood pressure is highest in the aorta and declines throughout the length of the pathway. It's about 0 or so when we get back to the right atrium. So you see here, blood pressure is highest in the aorta, then out to the more peripheral arteries, the arterioles, the capillaries, and then we have a dramatic decrease in blood pressure, right? So venous blood pressure is steady. Cut vein has even blood flow, even though a lacerated artery flows in spurts. If you've seen lacerated veins, it's sort of a constant blood flow. And then we have low capillary pressure, because capillaries are one-celled blood vessels, so you don't need that much pressure. And since there's small pressure in the venous system, blood flow returns to the heart by two methods. Number one is the respiratory pump, as pressure changes in the thoracic region due to breathing, sucking the blood towards the heart by squeezing local veins. And this can be inhibited by things like COPD. And the muscular pump, which is contraction of skeletal muscle compressing the veins and pumping blood back toward the heart. All right, so if we take a look at a lower leg, you see these are the two heads of the gastrocnemius muscle, your calf muscles, your more superficial calf muscles, your gastroc. And here's the vein that goes throughout the legs, and this is just to give example that the muscles contracting would help to push blood back to the heart. These are varicosities, varicose veins. The valves in these veins are no longer functional, so very commonly blood starts to accumulate. You get edema, you have poor blood flow circulation in the lower legs. So maintaining blood pressure is this delicate little ballet, and it requires cooperation of the heart, the blood vessels, and the kidneys, and we talked about the kidneys before. Supervision of the brain, and involvement of the nervous system, blood-borne chemicals. We talked briefly before about baroreceptors, which are specialized pressure centers found in the aortic arch and in the carotid sinus. The little piece about watch your hands means that very commonly, not amongst you guys, but among younger / newer healthcare professionals, you very commonly see them taking carotid pulses with both hands, which will promptly make your patient pass out. Very similar to doing carotid sinus massage in someone who has maybe an SVT. So when you're putting your fingers up and palpating that carotid pulse, you especially want to make sure you're not doing it with both hands. You want to make sure you're not really fuddy-duddying around in that area. Just go, try and palpate the pulse, and move on. Chemoreceptors and baroreceptors. Many of you might remember the macula densa, a specialized group of cells that line the wall of in the kidney. Very sensitive to the concentration of sodium, and we'll talk about the renin-angiotensin-aldosterone system, everybody's favorite. So we're going to stop here for a bit. I'm going to come back and record part 2 in a couple of seconds. Thanks.